Hello, I'm Shaun Treweek and I'm a health services researcher here at the University of Aberdeen.
And my name's Graeme MacLennan. I'm currently the Director of the Clinical Trials Unit here in Aberdeen, and I'm a statistician by training.
What we're going to talk about today is the PRECIS-2 tool, and Graeme and I are going to give some examples of trials which are at the more explanatory end or the more pragmatic end to give you an idea of how each of the domains works. And the first domain we're going to kick off with, Graeme's going to help us with, is the eligibility domain.
Yeah, so every trial, Shaun, needs to have some eligibility criteria to decide who gets into it or not. An example of a trial that would be highly explanatory is the COVID vaccine trials that excluded pregnant women, for example. So now pregnant women are left not knowing whether they should take the vaccine or not. Of course, a pragmatic trial would have included those women.
So if we move to the next domain, then that domain is recruitment. How do people get into the trial? And if we think of a trial, let's say it was done in primary care, then if they were taking a very pragmatic approach to recruitment within that trial, what they might do is use methods that could be used within the delivery of that treatment within primary care, maybe sending letters out or asking people at the point of having a discussion with the general practitioner. If they were using highly explanatory methods, then they'd be doing things like, well, let's have a radio campaign. We'll try and get people in on the radio. Why don't we also have things on TV? Why don't we hire some extra staff and get them standing around in the clinics to bring people into the trial? So it's these different approaches to recruitment, from something which we can imagine being done routinely through to things which really we can't seriously imagine being done routinely. That would get people into the trial, but is not a pragmatic approach.
Okay, so the next domain is the setting of the trial. Now, that's often a tricky one to assess because you need to have an understanding of the health service where the trial is being set. But a really sort of straightforward example is to think, is the intervention going to be delivered where it's going to be if it's adopted into practice? And that often is not the case in surgical trials, where surgical trials are tested out in expertise centres where they're really good at the operations. So a trial like that would be an example of an explanatory trial. A more pragmatic trial would include all sorts of hospitals and surgeons that were at varying stages of expertise in that operation.
Okay, and the next domain, now this is a tricky one for many, which is the organisation domain. And what this really is trying to tap into is, what is the trial team throwing at the trial to make it possible to deliver it? So if we imagined a highly pragmatic approach, then the team is not really throwing anything at it. They would be using existing staff. They wouldn't be very much additional training required. It would be the same levels of expertise. That would be a pragmatic approach. But you could easily imagine a much more explanatory approach where they think, right, well, we're going to struggle to do this unless we get 2 extra staff in each clinic. So the research team will hire new staff and put them in the clinic. Or they need to be very highly trained staff. So they'll just deliver that training for members of staff who they think have the right levels of competence already. If you withdraw that, then that makes it difficult to imagine that treatment being delivered, because it only got delivered because of this extra staff.
Yeah, and I think setting and organisation are intrinsically linked like that, where, if the setting requires lots of extra resource, it is naturally going to be towards the more explanatory end. Exactly. Yeah. Okay, so again linked to that is the flexibility of the intervention. I'm going to use another surgical example for that because I do quite a lot of surgical trials. So if you can imagine a clinical trial where you're comparing 2 operations, if what the surgeon does is up to the surgeon, and just the approach is philosophical, using keyhole surgery versus open surgery, and then they can pretty much do what they want otherwise, as they do in their local hospital. That's much more towards the pragmatic end. But an explanatory trial, everything about the operation would be dictated to from the protocol, including the material used, the type of stitches they had to give. They might even only be allowed to use like one manufacturer's tools or prosthesis or implants or anything like that. So that would be highly explanatory.
And similar to, in principle at least, to flexibility of delivery, that's from the health professional side, is flexibility adherence, it's called, in the PRECIS-2 tool, which is about what the participants themselves may or may not be asked to do with regard to adherence. So if we were thinking of a trial that was a home-based intervention, so why don't you do some exercises at home? If you were taking a very pragmatic approach, you might give them a booklet, you might have invited them in once or twice for a chat to tell them how to use it, but then you leave them on their own. And that would be a highly pragmatic approach. You're not checking what they're doing, you're not seeing whether they do it correctly, you're not seeing whether they do it in the right order. You've delivered it as you imagine it to be delivered in routine care. If you took a more explanatory approach, then you might be thinking, right, well, we're going to keep checking up, so we'll phone them every week, ask them how they're going. If it sounds like they're mixing up the order of the modules in the book, then we'll bring them in and we'll have another chat and talk to them about how important it is to do things in the right order. So that difference from highly explanatory to highly pragmatic is all about how much attention you pay to what they are doing and whether you intervene if you think they're not doing what you want them to do.
Okay, Shaun, the next domain that we're going to talk about is follow-up, which is where we measure the trial outcomes. Again, this is a tricky one sometimes to adjudicate on. I think the trials that are towards the more pragmatic end tend to make use of information that's collected already routinely in the health service. So trial participants and trial staff need to go to very minimal extra effort to deliver outcome data. So things like, for example, death, or if you're doing knee replacement procedures, they routinely collect the Oxford knee score, which is a measure of knee function. So that's collected routinely, but it's only collected up to 6 months. So, if you're moving beyond 6 months, the trial tends to get less pragmatic. If you're interested in lots of intense detail and repeated measurements that require participants to have to come into the hospital or respond to questionnaires frequently that they wouldn't have to do, that drags a trial much more towards the explanatory end, and particularly if it involves an in-hospital visit, that makes them, giving blood tests and whatnot.
And that leads us on nicely to the next domain, which is the primary outcome, the main outcome, if you like, for the trial. And if we take as our example this time, we'll have a trial which is really interested in something to try and help older people have fewer falls. So let's say it's a program out in the community. And if you were taking a highly pragmatic approach with regards to your selection of the primary outcome, what everybody is interested in is, does this thing reduce the number of falls that an older person has? So the very pragmatic outcome would be number of falls. However, you might think that's going to take me a very, very long time to have enough falls, or you just think it's too complicated. So an explanatory approach would be, okay, well, why don't we measure bone density? And that is something which has been done very often, is we'll measure bone density and we'll use that as a sort of proxy for what we're really interested in, which is number of falls. If bone density is higher, we imagine there'll be fewer falls. So that approach to the primary outcome has a big impact, in my view, on who can use those results and the level of confidence we can have in what they're saying. So again, it's about how useful is the outcome for the purpose that you intend to use it. And explanatory outcomes are more restrictive, but maybe exactly what you want for a particular purpose, a developmental purpose. Does it help us believe that it's worth doing that larger trial? But if what you're trying to do is inform clinical practice, then you need to be very careful not to choose outcomes that are really not going to help that discussion.
How you analyse that outcome, that's what we're going to talk about next, which is the primary analysis approach. This also involves considering the two flexibility domains previously, and to a certain extent the follow-up regimen that the trial has. Now, most pragmatic trials are interested in what I call comparing policies, or a policy evaluation, where what's going to happen in a health service if you do X or you do Y. A good example is apps. So apps are increasing in popularity, but often people don't use them properly. So if you make the app, you want to know how does the app affect health if it's used properly? But if you're the NHS, for example, you want to know, how does the app work if we just let it loose in the wild? So the way we'd analyse that from a policy perspective is called an intention to treat analysis. So you essentially analyse people as they're randomised. So if they don't use the app properly, if they don't download it, you don't exclude them from the analysis, you still include their outcome data in the analysis as if they'd used the app properly. That gives you that policy evaluation effect. The other thing that feeds into that is missing data. And of course, all of these things, the setting, etc., is how do we handle missing data? So ideally, we'd have no missing data. An intention to treat analysis strictly should make some assumptions about missing data and impute what they are, which is a fancy word for guess. If we were to exclude missing data and then say, for example, exclude participants for a trial that didn't use an app properly, we would be estimating what's called a per protocol effect, and that's much more towards the explanatory end, which is of less use to policymakers, but is of interest to, for example, you as a potential app user. You might want to know, how will the app benefit me if I use it properly? So at the pragmatic end, we've got this intention to treat analysis, which gives you that policy estimate. And then towards the more explanatory end, we've got the per protocol. Does it work if it's used properly? Both of which are of interest, but for pragmatic trials, it's the intention to treat we want to know.
Okay, so hopefully that has given you a bit of an idea of how trials can be moved from highly explanatory to highly pragmatic. But you'll find many more examples in the publication within the BMJ, and the link to that is at the end of this video. What you can also do, of course, is send in questions on the discussion board for this course.